women with breast cancer who are undergoing preoperative chemotherapy. Women who can stick to the fasting protocol are 4 times more likely to have their cancer completely disappear, going onto that higher curve that we talked about, whereas women who can't perform the fasting, can't get through it for one reason or another, which is often just the lack of support on the medical system,
right?
The knowledge and access. But if you don't achieve it, then they are almost never going to get a pathologic complete remission.
Hi, and welcome to the Women's Handbook podcast, where we discuss everything women's health from menarche to matriarchy. I'm Dr. Natalie Hutchins, and today we are talking all things breast cancer. Now, whilst it's not the number one killer of women, it is the most commonly diagnosed cancer in women worldwide, and the numbers are still rising. In the UK, around 1 in 7 women will develop breast cancer in their lifetime. And although here in Asia it is less common than that, rates have been rising rapidly over the past 2 decades. And as with many topics in women's health, there is a lot of confusion and misinformation around breast cancer, from when to start screening, to mammograms and whether or not they actually give you cancer, to whether you can use food to treat your breast cancer. So I'm really pleased to be joined by Dr. Stephen Tucker today. He's a UCLA-trained medical oncologist with an interest in digital health, lifestyle medicine and longevity. He looks after women with breast cancer every day. So if there's anyone that can do justice to this topic, it's him. So let's get started. Hi, Steve. How are you?
I am very well. How are you today?
I'm really well. Thank you very much for joining us today.
Thank you for inviting me. I'm excited.
Of course, I'm really pleased to have you here. Now, let's get into it, because I think any woman listening to the fact that breast cancer cases are on the rise would be alarmed. I think we all know someone who's been affected by breast cancer, who's seen someone go through treatment, if we haven't already been through it ourselves. So can you help us explain kind of what is going on here? What are the factors at play that mean that breast cancer cases are on the rise?
It's shocking how many people know someone who has had breast cancer or is going through it. I don't think we have any hard evidence on why we're seeing the increase in incidence, but what gets cited is a lot of metabolic factors, inactivity, alcohol, weight management, later pregnancies, diminished breastfeeding, a lot of those issues, a lot of attention, certainly social media, and it's easy to start blaming microplastics, nanoplastics, endocrine disruptors. I wouldn't minimize those. I just don't have enough evidence. I do have a belief, a non-evidence-based belief, that these are a significant factor in young onset cancers, including breast cancer. There's also screening. And I think that in Western and developed countries, screening is not so much finding the early cancers as often as it is maybe in Asia.
Right.
But I think that advances in screening also make us more aware. And advances in treatment give us better survivorship. So better chance that we all know someone who's been through this.
Absolutely. I was going to say, even though cases are rising, actually we're seeing that mortality is actually reducing.
It's slowing down.
Yeah.
Absolutely.
Which is the good news. The one thing that I suppose seems most alarming is that some of those cases of rising breast cancer incidence are actually in younger women, so in women under 40.
Correct.
Help us put that into context, because I know that it is still rare, but just hearing that sounds incredibly worrying. Help us put that into context.
The breast cancer rates, for listeners, incidence, number of new cases per 100,000 in the population. It's pretty much an exponential rise from about age 40 to age 70. So if you begin breaking it down by decade of life, you can start saying that, okay, in women between 60 and 70, there might be 300 cases per 100,000. Whereas in age 30 to 40, there might be 30 cases per 100,000.
Yeah.
And those are, I'm throwing out numbers, those are not the quoted
exact
statistics,
numbers.
but you can get a relative understanding of how frequent it is, because cancer is a disease of aging, most commonly. When you get to this younger cohort under age 40, there is an increase. It's not just our awareness. There is a It's a segment that has a increase relative to its historical pattern, about a 1% per year increase, which on 10 years is a significant increase, but it still makes up, depending whether it's USA, Asia, or Singapore, between 5 and 10% of the total number of cases diagnosed countrywide on an annual basis. But those young women always catch our attention.
Mm.
And it's not just the statistics. Anecdotally, in practice,
Mhm.
I am seeing more women under the age of 45 being diagnosed, and currently have a significant number of women in their mid-30s
Goodness.
with significant breast cancer. And they don't, we've tested them for genetic
Mhm.
susceptibility. DNA is not destiny, it's
Mhm.
susceptibility.
Yeah.
But in these cases, it's not genetic, which it often is in a younger case.
Mhm.
But it is definitely a phenomenon, and what the cause is unclear.
And is there something about those women that you're seeing in their 30s and 40s that is different? So is it that they've got a different subtype of breast cancer? We talk about breast cancer as if it's just one disease, but we know that that's not quite right. And it's actually an umbrella term for lots of subtypes. So is it that those younger women are getting a different form of cancer?
They present with pretty much the same representation as all of breast cancer. There may be a little more tendency towards the non-hormone positive.
Mhm.
Um, Before I let us all stumble on that, let me back up for your listeners. As you said, it's an umbrella term, breast
Mhm.
cancer. When we started in medicine, we said that's breast cancer and that's lung cancer. We name cancers historically for where they start, not for where we find them. You and I are, British and American,
Yeah.
but we're here in Singapore.
Oh, yeah.
And the breast cancer subtypes, however, is something that, whether it's pathology or molecular biology, advanced genetics, we can now subtype breast cancers most commonly into four groups:
Right.
hormone positive, hormone negative, triple negatives, HER2, these markers, right?
Yeah.
You see more of the HER2 positive
Mhm.
and the triple negative subtype in these younger women,
Right.
especially in the triple negatives if there's a family history.
Right.
And that's a clue that it might have a genetic susceptibility, the famous BRCA1-2 collection of genes. It's not just those two genes, it's actually 5 or 7
Mhm.
that work in concert. But it's also kind of mirrors the whole, histology, the 4 different groups. There are hormone positive early breast cancers.
Right. Okay. And for those women that get the triple negative, what's the prognosis like for them? So if you are a woman in your 30s and 40s, unfortunately diagnosed with breast cancer, are those more likely to be aggressive? Does that tend to affect your survivability?
It's a great question, and it comes up all the time, and the answer is yes and no.
Okay. Tell us.
So triple negative breast cancer is considered the most aggressive form.
Mhm.
HER2 positive breast cancers are considered an aggressive form. And historically, we found these subtypes because we looked at the whole group and we said, why did these women not do as well as the rest of the group?
Mhm.
And then we found the markers.
Yeah.
But we also have medications that are specific for those subtypes now. And therefore, even though they're highly aggressive, we actually can put them often in a better curve, in a better statistical group if they respond to the treatment. The more aggressive and the right treatment, we actually get a better result. For
Right.
example, triple negative breast cancer is treated most often with chemotherapy and immune therapy before surgery.
Right.
So you get better outcomes in triple negative and in HER2 positive
Mhm.
with preoperative treatments that respond.
Okay.
Now, what if you don't respond?
Mm.
And the response rates of it all disappearing, between 60 and 70% are
Right.
being cured preoperatively.
Okay.
So that's still 1/3 that I have to have a discussion, say, well, you went to surgery, there was residual cancer, a little bit left. It was 90% gone, but it's not 100%. Now I have the opportunity to give you a different medication that might be more targeted to the residual cancer. So in the past, we would just be treating blind.
Yeah.
But now I know that you're in this actually higher risk group. I can, and I'm going to say this a few times today,
Mm-hmm.
I can offer you risk-adapted treatment.
Right.
I know we're going to talk about screening
Yeah.
and we're going to talk about prevention.
Yes.
The phrase that I like, and you can call it personalized medicine,
Mm-hmm.
but what I really like is risk-adapted screening
Okay.
and risk-adapted prevention. And both of those are for people who've never had breast cancer.
Mm-hmm.
And the risk adaptation is not everyone needs a mammogram at 40.
Okay.
Sometimes you need an MRI at 25.
Yeah.
Sometimes, if we really think that breast cancer is a low risk in life,
Mm-hmm.
based on a conversation,
Yeah.
based on genetics,
Yeah.
based on personal behaviors,
Yes.
and family history, different
Mhm.
than genetics,
Yeah.
we might say someone has average to low average risk.
Yes.
You might want to think twice about doing the mammogram every year versus every other because of the do no harm.
Yeah.
What happens with a false positive?
Yeah. And it's a
Yeah.
balance of risk, isn't it?
It is.
Oh,
And it should be an informed decision, a shared decision. And what that requires is a relationship with a doctor,
mhm.
not just a screening, mammogram in a mobile, truck,
Yeah.
but an understanding of the possible harms of the medical system.
It's about interpretation, not just about doing the test, but it's about being able to interpret it in the context of that woman's life as well,
Right.
isn't it? Yeah.
What kind of person are you? Are you
Yeah.
information savvy?
Exactly.
You could be a fearful person
Mhm.
whose best friend died of breast cancer, and so you want to do everything.
Mhm.
On the other hand, are you capable of internalizing that information?
Yeah.
Are you going to worry so much that the worrying diminishes your own metabolic health?
Absolutely.
It's a real balance.
And affects all the things that lifestyle things that we know can impact on, cancer risk. So sleep and stress and all of that
that
type of thing.
huge psychological load that translates into adrenaline, cortisol,
Mhm.
and metabolic health.
Yeah. Okay. Just to backtrack a little bit, because you mentioned immunotherapy for breast cancer in these women. And I think a lot of people will have obviously heard of surgery for breast cancer. They would have heard of chemotherapy. They would have heard of radiation, not necessarily immune therapy. So can we just have the layman's view on exactly what that is and what it entails?
So immune therapy is using medications, and there are a few different categories of immune therapy that are targeted at certain markers on the surface of a cell that activate the immune system in a novel way that, in a sense, the cancer had turned off.
Mhm.
It in some ways makes your immune system hyperactive,
Right.
and it makes it so that cancer cells that were hiding behind markers of self, our body knows that not to attack our own thyroid gland.
Mhm.
Our body knows that, my hair follicles are mine and not a hair transplant.
Yeah.
And well, maybe I just kidding. But in this case, these medications, which are antibodies,
Yeah.
so engineered, antibodies, similar, immune response, that then target, flag, signal our immune system to identify these cancer cells. And it's not just attack the cells, it may make them more susceptible to the chemotherapy. It may change the cell signaling so that these cells that were hidden from surveillance are now more aware.
So essentially, you're saying that actually you've got a whole plethora of tools that you can use in your toolkit for women with breast cancer. Not just the chemotherapy, you've got the radiation and immune therapies.
And targeted therapies.
And targeted therapies.
Or new oral non-chemotherapy medications, cell cycle disruptors.
Mhm.
And we will get to, we'll talk about metabolic health.
Well, this is what I was just about to go on to as we were talking about treatments. It's a little bit controversial. I think what's not controversial, as we've both said, is that lifestyle has a huge impact on cancer prevention and your risk of recurrence. And I think all the medical societies and the cancer societies worldwide agree with that. And obviously that includes nutrition. But what is more controversial is the metabolic theory of cancer progression and initiation. And the idea that you can use nutrition to treat cancer. So I just want to show you a video to set the scene.
Okay.
And then you can tell me what you think.
A solution to the cancer problem, to manage cancer without toxicity, is to simultaneously restrict the two fuels, glucose, which is already in our bloodstream from the food we eat, and the amino acid glutamine. If we stopped eating and we took a low carbohydrate diet and just did water-only fasting, we would get into nutritional ketosis. The tumor cells have a bad mitochondria. They're dependent on glucose and glutamine. We can replace glucose and glutamine with ketone bodies. So we selectively marginalize these tumor cells slowly over time. They slowly start to die, the blood vessels disappear, and the body comes in and dissolves them.
That was Thomas
Seyfried.
Seyfried, and he is getting lots of traction. He really believes in this theory, and obviously it's incredibly interesting from a research point of view. What do you think?
It's interesting you say he's getting a lot of traction because he's been doing that for 25 years. So, and I think he had a lot of traction before, and he still has traction, and it can be amplified on social or other places. I am a believer with caveats. I'm fully on board. One thing about my training, I actually dropped out of medicine at one point. I like to say dropped out, but I got a fellowship and left medical school and went to a place called Rockefeller University.
That is definitely not dropping out.
Yeah, no. But it sounds so much better when you leave medical school to move to New York and study nutrition, which, as the cliches always go, doctors get an hour of nutrition in their medical school training, maybe a day out of the 4 years. And I spent a year studying nutrition, which really means energy metabolism and human behavior. And that was the name of the laboratory at Rockefeller University. And I worked on neuropeptides involved in feeding hunger and satiety. One of my colleagues was studying fat cells. We were, it was the early 90s, and something called chromosome walking. We didn't have next-gen sequencing, but we were working with these obese laboratory rats.
Right.
And we would be able to predict which of the newborn pups would become obese. And we even had human patients, real people, coming in, spending a month at a time with us, where we would flip a coin and reduce their caloric intake by 10 or 15% in a controlled environment.
Yeah.
So this whole panoply of studies on nutrition, it's been critical, which is why I know about Tom, and it's been important in every aspect of medical care that I've been involved with through the rest of my clinical career, because what we eat really matters. And the carbohydrate metabolism of cancer cells can be manipulated.
Okay.
Now, this is where depends comes in, because that doesn't mean it can be cured. I think that the metabolic theory of cancer is incredibly valuable in a rare tumor, which doctors know, glioblastoma multiforme. So horrible brain tumors really respond well, especially pediatric brain tumors respond really well to a keto diet along with other metabolic interventions. To go back on Tom and metabolic theory, you have to, if you rewind the history, the biggest punctuation mark you'll hit first is the Atkins diet. And Atkins gets a bad rap because he was a great marketeer and had built a great business. But the low carb aspect of Atkins was the same thing that Tom's talking about. But what Atkins was doing was only rediscovering what the French had been doing and what Johns Hopkins had been doing 100+ years ago. The keto diet was first formulated prescriptively at Johns Hopkins for pediatric seizure disorders. And so again, through manipulating the mitochondria, the glucose metabolism and energy metabolism, that is a really successful treatment for select seizure disorders in adults and children. Now, what does that mean today in breast cancer? The low carb diet is important, or maybe it's better to say that a highly processed diet is unhelpful. And low carb diet is also a funny term because I can get fairly pedantic and prescriptive myself. Somebody says they're doing keto, I'm going to ask them how much fat they eat, and they don't realize that the keto diet is actually 70% energy from fat. That's 1,400 calories a day on an average American male. That's a lot of coconut oil, which we don't always recommend.
Yeah.
And someone thinks if they eat a porterhouse steak that it's a fatty product. Well, it's mostly protein with some fat in it. And so people aren't really doing keto diets, and your low carb and my low carb may be different.
Right.
But I think getting rid of the processed food and the ultra processed food is really the issue.
Okay. So you feel that it is definitely important, that metabolism is incredibly important in the initiation of cancer and the progression. But you're not necessarily recommending the ketogenic diet to all your patients, or are you?
I am not recommending the keto diet to my patients at this time. I would say that our practice was the place in Singapore for a very long time to get the supervised ketogenic diet. I have 2 or 3 nutritionists. We have a nutrition coach. We have counselors. This integrative approach, multi-specialty approach to cancer care, to screening, prevention, treatment, and survivorship has been, the passion project we've built over the last 15 years. And so I had one of my dietitians who's a vegetarian. I credit her with being open to the keto diet and prescribing it to our cancer patients. First caveat, we're talking about stage 1, 2, 3.
Okay. That's important.
Patients we're treating with curative intent.
Yeah.
Second, she gave me the phrase that what we offer is culturally appropriate nutritional support.
Okay.
I really like that. I don't recommend a diet to someone. There's no one size fits all. When the patients come to me and say, can I do this? Can I do that? How does it fit into their lifestyle? Is it sustainable? And we did use the keto diet a lot. It was a great and is a great weight loss tool. It's an intervention. I don't think it's a lifestyle for the vast majority. It's not sustainable. And it may be fairly unhealthy in the long run.
That's what I was going to ask you about.
It depends how you do it. There's clean keto. There's dirty keto. The issue is, why are you doing it? Are you doing it for weight loss? Okay, we can do that for 6 months. We can use it to go from one state to a better state, but maybe there's a maintenance diet that's better.
Absolutely.
Now, we really don't do that much keto work anymore because Ozempic and Mounjaro, semaglutide, tirzepatide, all of these drugs have completely changed the game.
Right. Okay.
They have completely changed the game in helping us restore metabolic health.
Okay. I want to get back into that. I suppose I just wanted to go back. So the reason why I said Thomas Seyfried's theories are gaining traction, it wasn't necessarily gaining traction in the medical field. Obviously, he has been going for a very long time, and he very much believes in this and has built his career on it. It was more that it's gaining traction within patients in the general population, who may not necessarily understand all of the kind of the nuances of what he's saying. And I suppose we as doctors, whenever we're talking, to the public, have a responsibility to make sure that we're saying the right thing with all the nuances, and we're not misleading people. Because I think just seeing on social media the following that he's got, and that others like saying the same thing like him that have got. And then on the other side, you see cases where people are dying from their cancer because they're going down the alternative route. We need to make sure that we're really balanced in our messaging. So just in terms of if you've got if someone's listening to this and they've got cancer, just explain what you're saying in terms of whether you think it will help, whether you think it will cure them, and if this is something they should be exploring on their own.
So first, I think the high level is nutritional interventions are not curative interventions.
Okay.
So I would not abandon conventional therapy for any form of nutritional therapy. And I would also point out, even within our medical specialties, we wouldn't abandon radiation for medication. We have to work in partnership with the tools available. And in this case, we do not want to abandon drugs, radiation, surgery for just nutrition alone.
Mhm.
Nutrition is incredibly important at all phases, the prevention, the treatment, the survivorship.
Yeah.
How we do it and how it gets integrated and when it gets integrated becomes an important topic. I'll give you an example, and I don't know if you were going to go here, but
Mm.
we do recommend fasting.
Mhm.
So I'm a big advocate for fasting and what's called a fasting mimicking diet during chemotherapy for patients who are undergoing treatment, which achieves similar goals to the keto diet. Because whether it's keto or low carb or fasting, what we're really talking about first is the elimination of the sugars
Mhm.
and understanding that cancer cells are glucose dependent initially. If they were always glucose dependent, maybe you could talk about keto being curative, but there is no way to rid our bodies of glucose. And the body will also use glutamine. And we definitely have experimental drugs that block glutamine, but they kill patients too.
Oh,
So
okay.
they're toxic. So
Okay.
we really need our glutamine to
Mhm.
some degree.
Mhm.
Now, how does fasting work? And this is where metabolic theory gets applied. And the person who gets the most credit here is Dr. Walter Longo,
Mhm.
who's also in the world is adopting his views as well. Here's the catch. So the cancer cells are addicted to glucose. And when we fast, our body's metabolic rate slows down.
Mhm.
But cancer cells being mutated ignore the signal. Okay, the example that's often given is if it's raining outside, you open your umbrella. You got the signal.
Yeah.
Cancer cells ignore the signal. So now these cancer cells, which are hypermetabolic and ignore the signal that the body is fasting, they keep demanding whatever glucose is left over. And you go from a blood glucose of 100 down to a blood glucose of 70, and you might feel a little lightheaded. Maybe you feel comfortable, uncomfortable. But those cells are, I call them wobbly. So now they're like, where's my next meal? Where's my next meal? And they're a little unstable. At the same time, our healthy cells, the stem cells in our bone marrow,
Mhm.
the stem cells lining our gut, the cells protecting our hair follicles, all slow down. Now, chemotherapy works by incorporating itself into cells that are rapidly dividing. So we just laid out a scenario where the cancer cells are still going full speed, but the rest of the body slowed down. So you get this double benefit where fasting for 24 hours before and after chemo
Mhm.
causes less toxicity on healthy cells and theoretically gets a better outcome in killing cancer cells. And this has been shown in randomized clinical trial data. Not the best and most robust data in the world, but it's decent data,
Mhm.
particularly in preoperative women with breast cancer who are undergoing preoperative chemotherapy. Women who can stick to the fasting protocol are 4 times more likely to have their cancer completely disappear, going onto that higher curve that we talked about.
Mhm.
Whereas women who can't perform the fasting, can't get through it for one reason or another, which is often just the lack of support on the medical system,
Right.
the knowledge and access.
Mhm.
But if you don't achieve it, then they are almost never going to get a pathologic complete remission.
And why is this not part of standard protocols then?
I don't think it's crossed the evidence-based medicine threshold at the randomized phase 3 level,
Mhm.
and it's very hard to achieve those studies.
Mhm.
I point out it's stage 1, 2, 3, and its safety. I mean, there are a lot of studies that show the safety of this fasting protocol around chemotherapy. It reduces the toxicity. It might enhance the benefits. It certainly has suggestive benefits in these, early randomized phase 2 studies and smaller studies, but again, not the gold standard double-blind randomized
Mhm.
New England Journal study.
Mhm.
But there's not really a great harm here. When performed with the right education, setting, and support,
Mhm.
it's quite doable. But do all the medical teams, all the oncology practices, do they have the resources? We're quite fortunate. I mean, I have, nutritionists literally sit in with all new consults with me as a medical scribe. And then when someone asks a nutrition question, I'm like, well, we have a nutritionist with us.
Here you go.
And we provide for our cancer patients, the nutrition support is just embedded in the care. If you send your grandma for protein advice or a kidney case, we charge consult fees.
Yeah.
But for our oncology cases, this is just part and parcel of the kind of care that we give.
So interesting. I suppose one of the criticisms, you said there isn't much harm, but I suppose one of the criticisms that float around about these types of protocols is that in cancer patients, often they've lost their appetites, they might be cachectic, they may, be losing weight at a very rapid speed. And often, or in conventional medicine or traditional medicine, the focus there has been on let's build them up, let's give them supplements to, those shakes. So tell me about that contradiction.
I love that you asked that. You kind of fell into it because I prefaced this with stage 1, 2, 3. And stage 1, 2, 3 means these are patients, whether it's breast cancer or any cancer, they're not metastatic stage 4. When we bring up stage 4 patients, we have to use all the framing that you just brought up. I can't safely use fasting all the time, or often, say in stage 4 pancreas or lung cancer. Those patients are losing protein, are losing weight, and they have been robbed of appetite by the cancer. A stage 3 patient, lymph node positive breast cancer, who's had surgery, is theoretically cured. And more likely than not cured with surgery alone. Stage 3 patients, historically 60-70% cure rate with surgery alone. So they're a fit young crowd. And of course they can do some fasting. These are just manipulations that people are doing all the time. So there's really no to limited danger in stage 1, 2, 3 in a properly educated population. I think the biggest danger is pinning too much value on it.
Yes.
Like overselling it. This is not the cure. This is a manipulation to help us get better cures, but it's only part of a larger recipe.
Yeah.
But you're right. Stage 4 is a completely different balance where we often have to get more protein, more calories. We might be looking at how are we going to break the cycle of cachexia and wasting, where fasting and low-carb diets might not be the right way to go.
Understood.
Yeah.
Okay. And so how long, with your patients who are going to go on a fasting protocol, how long usually are you asking them to fast for?
In a standard chemo cycle, which might be every 21 days, we like them to fast for 24 to 36 hours before chemo and 24 hours after. So 2 to 3 days. If they've never fasted before, we might even just start with 12 and 12. We might go to 24 and 12. And you can use this fasting mimicking diet, which was developed by Dr. Longo at USC, which gives you the social opportunity to chew.
Yeah.
It's a very high fiber, low calorie, broths and crackers, nuts that are not going to spike your glucose.
Okay. So they do those fasts at those prescribed times. And then in between that, they're then eating a diet which is low in processed foods, low in sugar, low in refined carbohydrates.
Ideally.
Where the crossover, we talked about the keto being unhealthy. And I think that's maybe why I kind of have some issues with it, because again, it's that contradiction. On one hand, we know that excessive red meat is not healthy for us. We know that excessive saturated fats are not healthy for us. We know that having lots of fiber in our diet, which often may come with carbohydrates, is very healthy for us. So again, there's that contradiction in terms of what you're saying about the ketogenic diet and what we know is appropriate for long-term health. And that might be because of the timing. So you mentioned it's about the right diet for the right time. So are you saying that the reason why why you feel the ketogenic diet is appropriate in these cases is because you know you're only going to be using it for that 6 months.
So when we're using keto as opposed to low carb, there's some caveats. One is nobody said red meat is required in the keto diet. You can do a vegetarian keto diet. It's hard. It requires, a nutritionist to really work with you, but you can absolutely do a vegetarian keto diet. What we need to think about is set and setting. So keto diets, I would say most often come up in the non-cancer population, more men than women, and guys think it's really easy to lose weight on a keto diet, and they're happy to go have, steaks at a steakhouse and, maybe some vegetables or not, but they're more carnivore, okay? And again, the red meats are not a requirement, but protein is. Now, people are overdoing protein. That there's no question. You have to find sufficient protein, which is probably 0.8 grams per kilo is sufficient. If you're athletic, maybe 1.2 or 1.5, very athletic. But people doing 2 and 3 grams of protein from various sources, bad idea.
Yeah.
Also, if you
tell us why you think it's a bad idea, because I've heard that before.
2 things come to mind. One is you might be having a lot of excessive red meat. Also, the kinds of amino acids that you might be taking within the context of your protein can actually be driving cancer.
Yeah.
That too much protein can be a driver of cancer. Certain amino acids, I think it's methionine and maybe lysine and cysteine, but are bigger drivers of cancer and neoplastic risk than others.
Yeah.
But the other more practical thing in this protein world of today is that a lot of protein powders have high amounts of lead.
Yes.
And the vast majority have too much lead. So there was recently an expose in Consumer Reports.
I saw it.
And it's absolutely a perfect article we send to people all the time. And in combination with what is sufficient, because most people have trouble getting, if I've got a 75 kilo man who's athletic, they probably need 80 to 100 grams a day. And that's hard. That's 4 healthy servings of protein. It's 4 chicken breasts potentially. And so at least getting 30 grams from a scoop of something in the morning kind of makes sure you get off on the right foot most of the time.
Yeah.
So it goes back to context. What are we trying to achieve and for how long? Is it sustainable? Because if you go back to my example, if I've got an obese 45-year-old man who wants to clean up his act and he's comfortable with keto, what is the risk of the obesity in him now compared to the short-term risk of the keto diet?
Absolutely.
So we also, before anyone begins, a keto diet, if they're 45 and older, we're going to check their heart. I take care of a lot of prostate cancer too. The number 1 cause of death in men with prostate cancer is heart disease.
Right.
And
it's the number 1 cause of death in women as well.
Exactly.
Yeah.
And it's completely overlooked. I was at a conference, I was telling you, last month, and I got to sit down with a cardiologist from the US who I felt like we were just old friends because he was giving a lunchtime table talk on why we need to treat heart disease like cancer. And I was drawn to it like a bug to the light. And he and I are texting constantly because he's as passionate, enthusiastic, and engaging about preventing heart disease as I am about preventing cancer and using evidence and personalizing on an evidence-based approach.
And do you know what else I think we should treat like cancer? Endometriosis. So,
yes.
In so many ways,
PCOS.
There are so many, there are so many similarities between the biology of endometriosis and cancer. And we have hormonal therapies for endometriosis, we have surgery, but you guys are so lucky to have all of these other things. And I think that's where the next improvement or the next development in endometriosis care is going to come from, is doing things like metabolic therapy and nutritional therapy. That we're getting emergent evidence now about the importance of nutrition, not only for treating endometriosis but preventing it. So I agree.
Absolutely.
Yeah, I think that's going to be important. You were going to tell me about GLP-1s.
So As much as we love our nutrition consults and our low carb, keto, fasting, nutritional interventions, they're very hard to sustain.
Mhm.
They're very uncomfortable. Where do the GLP drugs come in? These drugs are incredible at beating diseases, chronic diseases that are killing people.
Mhm.
And so these drugs have not met a condition that they didn't conquer on average. There's always exceptions, except in the domain of gastrointestinal problems.
Yeah.
They
Not
do,
great for that.
yeah, it's not that they cause exact problems there. It
Mhm.
is the site of most of their side effects,
Mhm.
and most of them are manageable. For a distinct group, it's intolerable, but the third generation drugs have less toxicity
Mhm.
than, and there's more and more of these drugs coming. So fast forward, we know that metabolic disease contributes to an increase in cancer and chronic diseases.
Yeah.
We know that metabolic disease contributes to the relapse rate in cancer survivors
Mhm.
and in, I would say, cardiac patients who've had their first stent or heart attack.
Mhm.
So these drugs are used in primary and secondary prevention because the risk factors are there and we can reduce those risk factors.
Right.
To the point now that there are 2 large randomized clinical trials being started internationally using the GLP-1 drugs after surgery for breast cancer.
Right.
And I would predict, at the risk of being documented in videos, I would predict that these drugs are going to have just as much impact in reducing the risk of relapse
Yes.
as chemotherapy or hormone therapy
Mhm.
in the long run.
And will you start using it now, or are you going
We
to wait?
do.
You do use it?
Absolutely.
Yeah.
Now, we don't frame it necessarily as you had breast cancer, you're at risk for relapse, take this drug.
Mhm.
It's you had breast cancer, you're at risk for relapse. You also meet the requirements for these drugs. You're a diabetic,
Yeah.
you have a BMI of 30,
Yeah.
those things. So it's not a
It's not the
classic
primary reason.
adjuvant,
Yes.
but that's the kind of care we've always given, and
Mhm.
and the what we think of in holistic, not in a woo-woo kind of
Yeah.
way, but in a comprehensive, clinic that's looking at all aspects of health.
So as opposed to the fasting, which you're using with patients who currently have breast cancer, actually you're talking about using GLP-1s to reduce the risk of recurrence.
Right,
Okay.
right.
Just building on from that, you've talked about some of the things that you do because of your belief and that biologically it makes sense to do so, like the metabolic theory, using GLP-1s. What do you think about the future of evidence-based medicine? Because it takes so long and it's so expensive to get these trials done. And on one hand, we have smaller studies, kind of less convincing studies that wouldn't make the New England Journal of Medicine. Where does the balance lie between personalised N=1 medicine and us still waiting for that concrete evidence, which we were trained on?
I think that there's a bright future for evidence-based medicine.
Okay.
And we still anchor to evidence-based medicine.
Mm-hmm.
And the example in the GLPs is still evidence-based medicine.
Mm-hmm.
It's just that we're using the timing is overlapping. That I'm saying the evidence says in obese, pre-diabetics with fatty liver, that's what the indication for GLP-1 drugs are. It just so happens that I'm an oncologist who's thinking comprehensively. I'm not saying go to the endocrinologist to get this or ask about this.
Yeah.
We're doing them concurrently.
Got
So we're not off the ranch
Mhm.
in that sense. I think the fasting protocol in preoperative chemotherapy is more off the ranch.
Yeah.
But I've got decent evidence and a safety profile that make this quite useful.
Yeah.
Here's where you're off the ranch. There's no evidence for rapamycin.
Mm-hmm.
There's no evidence for the keto diet. There is evidence for weight loss.
Yes.
And so how we achieve weight loss, then we're into a tactics versus strategy discussion.
Mm-hmm.
And so I think evidence-based medicine is still the bedrock that everyone comes to me for.
Mm-hmm.
And we Everybody loves longevity. They love biohacking.
It's so sexy, isn't it? Oh my
And
gosh.
I'm engaged. I am knowledgeable. I've been doing this for 20 years with digital health. I mean, literally, most people listening to this won't know what a Fitbit is. But we brought them into Singapore when they first got on the market because it was the entree to measuring and quantified self. But that being said, you still root your advice in do no harm.
Yeah.
And even you go back to the mammograms, do no harm. The evidence says to do it, but how do I personalize? How do I make sure that this mammogram is going to not result in harm in this person far down the line?
Yeah.
And that might even be mental health harm, the anxiety.
Yeah. Okay, let's bring this back to talking about risk. Okay, so as you said, it's all about risk adjusted. What did you call it?
Risk adapted.
Risk adapted. And I think it's important for everyone to know their risk. That's kind of the starting point, because that's when you know what screening you need, when to start screening, what modality you need. So let's talk about how women can work out which risk category they fall into.
What comes to mind is your family history. So if you can find out the basics of your family history for cancer, I would say for cancer and heart disease, that becomes very useful. The way to do that is all I'm going to ask you in this, questioning is, do you have brothers and sisters? I'll populate the tree first. So then I'm going to see your generation and your siblings. Your parents, are they alive? Does your mom have siblings? Male, female, are they alive? And the same for your grandparents. So we want to populate that tree. And then we want to ask, did anyone have cancer? Okay. Did they die from that cancer? So when they had that cancer and did they die from it becomes kind of important. If I have a tree that says my sister had breast cancer, my mom had breast cancer, my grandma had breast cancer, and my first cousin had ovarian cancer, and they all died at 45 of their illness, that's a BRCA 1-2 family.
Right.
And even if the genetics come out normal, it's a super high risk family. Now, same story, and people get breast cancers at 70 and they die of Parkinson's at 90. That's a different elevated risk.
Yeah.
Okay.
And that's very common situation, isn't it?
Yeah, where people, because then what you have to get into a little bit is, okay, what kind of cancer did Auntie have? When did she have it? That's where the naming comes in. We name it for where it started, not where it's found. Because how many times have you been at a cocktail party and someone says, my auntie has bone cancer? And we know sarcomas, bone cancers originating in the bone, are pretty rare, but cancer spreading to the bone is very common.
Right.
Gets complicated in Asia, like, oh, it was liver cancer. Like, oh, did it spread to the liver or start in the liver?
Yeah.
Both could be common in Asia. So, and then you want to know, did they actually die from the cancer? That becomes important.
Yeah.
You should ask the same thing about heart disease. I get kind of passionate about sudden cardiac death, and which is when people, for listeners, they're dying of an abnormal rhythm of the heart, not actual vascular disease. And there's a story that goes with it. You're like, oh, my dad died of a heart attack at 45, non-smoker, running a marathon.
Yeah.
And then the surviving son passes out in a cold swimming pool at age 12. Ding, 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 ding. This might be sudden cardiac death. You need genetics and to talk to a good cardiologist. So I start with our pedigree looking at heart and cancer to get those high level, information.
Yeah.
That might trigger us to offer proactive genetics. It's not a requirement to look at DNA, but I think knowledge is power.
Absolutely.
And again, you have to know your patient, because if knowing is going to make them more anxious, that would be a bad idea.
Yeah.
And if knowing empowers them to be more proactive, then that might be a good thing.
Yeah.
Because if we say that, mammograms as a general rule should be started and offered at age 50, to age 69, what do we do in the 40 to 50-year-olds, right? It gets controversial.
Yeah.
I have a slide I use every year in breast cancer talks that looks at what countries recommend at a country level, what societies like the Oncology Society, the Breast Surgeon Society, the Radiology Society recommends begin very, very early. And what do coalitions, like different partisans have different recommendations.
Yeah.
Now, here's the thing. Mammograms work. They work better these days in developing countries than developed. We might have overscreened Canada and North America. So we're not finding as many cancers or dangerous cancers as we used to.
Yeah.
But they're still valuable in the right population.
Okay.
But if you go back to the family tree and you can populate it with a lot of people.
Yes.
A big challenge. Only child, adopted.
Yes.
Adopted means get genetics.
Yes.
Or, parents were divorced. I never knew my father or that side.
Yes.
Or you know everyone, but your parents were both single, only child.
Yeah.
And you don't have a tree. You kind of have a little bonsai,
a little branch,
tree.
yes.
Right. So you don't know what could have happened. But if you have that big full tree and everybody lives to 90, you would say, I think appropriately, that person might be average risk. I might even say that they're at low risk,
Right.
especially if they're fit, they're not overweight, obese, not diabetic, pre-diabetic, and don't have fatty liver,
Okay.
none of the stigmata of
Yes.
metabolic disease.
Yes.
Then I'd be like, okay, let's go in eyes open,
Okay.
because mammograms find a lot of stuff. And it's our job as professionals to be cautious and say, come back again next year.
Yeah.
And sometimes we're overactive and we do have an overdiagnosis problem in highly screened populations.
Yeah.
But you can't tar the whole system with that. And in places like Asia, you definitely need screening mammograms because you have people who come from villages in Thailand and countries that are emerging where they haven't had access to as much screening and care.
Okay. So we talked about family history. Can we talk about some of the other things that would affect someone's risk and determine their risk category? So dense breasts, for example, how does that affect your risk score?
Dense breasts are definitely associated with an increased risk, but you would have to already be in the screening to know that you had dense breasts. So I think dense breasts, I struggle to find a report that doesn't say breast tissue was dense and
it's
limits
incredibly
the
common, isn't it?
sensitivity. I think that it's almost a medical legal phrase at this point.
Right.
So yes, it is a risk factor, but it's not a controllable one.
Yeah. What does it actually mean? So as you said, it's incredibly common to get that in your report, and a lot of women say, what on earth does that mean? What does it mean?
It means that it's harder for screening to be successful, that it may limit the value of screening. There may be some inherent biology that causes dense breasts that then subsequently increases risk.
Yeah.
But I view that as what we would in medical school describe as a field defect. And so it's not that dense breasts cause cancer. It's that breast cancer is more likely to arise in a field that is dense.
Right.
Just like it's an argument, does DCIS lead to breast cancer? Is the precancer stage 0, if you leave it alone, will it evolve into something more aggressive? Or is it a field defect that allows a breast cancer to grow more efficiently? And I believe more on the latter,
right?
That it's more of a field defect. There's data for both that you can trace genetic evolution of a cancer to a DCIS cell, but more often than not, just like lobular cancer and LCIS, it's a field defect that says in this background, you're more likely to get weeds.
Okay.
Your soil's not so good. Weeds are more likely. The bad soil didn't cause the weed.
Yes.
But it's just makes it easier to grow.
That's really interesting. Okay. So we've talked about family history and dense breasts. What about ethnicity? Does that have any bearing on your risk? And we see that in the US, Black women have the same rates of diagnosis of breast cancer as white women, but their survival rates are much lower. Is that just because of the social determinants of health and access to healthcare, or is there a biological characteristic that is genetically inherited in women of Black race that makes them more susceptible to aggressive cancers?
I think that probably the true answer is both.
Mm-hmm.
I would say it is overwhelmingly social determinants of health.
Okay.
Overwhelmingly.
Mm-hmm.
And social determinants of health, your zip code, your education, your peer group, your social media, all of that. As my digital health background,
Mm-hmm.
I have framed a thesis for years that there is digital behaviors, which are well documented in our devices and our phones, that give us the digital social determinants of health.
Yes.
And then there's digital biology, which is your genome, your pharmacogenomics, your phenome, appearance, microbiome, all of those omics.
Mm-hmm.
That's true digital health, is the marriage of digital behavior and digital biology.
Yeah.
And it's those social determinants are huge.
Mm.
When you look at metabolic fatty liver, when you look at obesity and diabetes, it absolutely co-locates with number of McDonald's and 7-Elevens, earnings, poverty, crime rates, homicides.
Yeah.
No,
Everything.
it's access to care.
Okay. Because on the other side, I was going to ask, then conversely in Asia, we see that the rates are so much lower of breast cancer in Asian women. And is that some kind of genetic advantage? But it sounds like you're going to say no.
So Asia is different.
Okay.
I think North America and African American patients and social determinants are a legacy huge issue. In Asia, you have soy-based diets. You have the breast cancer rates generally in Asia, and I remember some of the data from the Shanghai breast cohort. The rates of breast cancer, I think, have tripled in Asia and in Singapore in the last 40 or 50, at this point, probably 45 years. So what's different? I'll tell you one thing that's not different: the genetics. In the Shanghainese breast cohort, Shanghainese women have not changed in 50 years. So what did change? They went from, the women in Shanghai went from being in a rural, agrarian, low-protein diet to an urban-based, city-dwelling, processed diet with less activity. And I mean, that's an association, not a causation. But I think that's where the metabolic risk for cancers come in. It's not pollution.
Yeah.
It's really these metabolic risks because the DNA backbone didn't change. But it is interesting in Asia because the kinds of cancers and the presentation of cancer historically has been different. And a lot of that may be attributed to a soy-based diet as a protective feature against breast cancer.
And do we see when Western populations adopt a soy-based diet, I don't know if there are any studies that look at this, that you see a reduction in breast cancer rates, or has that not been done?
So soy-based diets and soy supplements have been extensively studied, often thought to be harmful in women who have been diagnosed with breast cancer, specifically hormone-positive breast cancers, because of soy's estrogenic properties.
Yes.
So if we have a hormone-positive patient, we wouldn't give, menopause hormone therapy, MHT, to a woman with hormone-positive breast cancer in the 5 or 10 years after. So why would we give a natural product that is going to cause the same effect or benefit? That's been extensively studied. And unless it's the extremes of soy is very safe for both hormone positive and hormone negative breast cancer survivors. Now, where does it fall in the prevention? Because that's really what we're talking about is, so maybe there's a protective effect of a high soy diet, which could be the protective effect of a low protein diet.
Right.
So we might be conflating one thing for another, confounding.
I see. Okay. What do you think of tools that are out there for patients to, I know that you're very much in terms of into patients kind of empowering themselves. I've seen you do lots of social media posts about using kind of ChatGPT to work out your risk on things and have a higher level discussion with your healthcare providers. So what do you think about tools that are available on the internet, like the Tyrer-Cuzick score, so that patients can use that? Because even though you talk about the tree, and we've talked about how many of the tree needs to be to think about having genetic testing. You know, if someone's got, well, my grandmother had it, my aunt had it, you know, does that make me high risk? It can be quite tricky to work out. So what do you think of those tools?
Well, I think my first answer is I love them.
Okay, perfect.
I embrace.
So do I.
However, one is you have to know yourself as the consumer, as the patient, as the client, whoever you are, as I like to say, the civilian.
Yeah.
Okay. Getting cancer takes you off the civilian playing field. It's so life changing. But as a civilian looking at these tools, they're informational, they're not diagnostic.
Okay.
And they can be empowering, but I ask you to ask yourself, how comfortable are you with information? Like, you know, that how do you know you're not going down a rabbit hole where, you know, if I order this test, if, you know, this, you know, marker, and then they're going to sell me something else. And the, you know, often a lot of these websites, I mean, Tyrer-Cuzick is, you know, different, but which is a breast cancer, you know, risk platform.
Yes.
But nutrigenomics is fascinating.
Yes.
But it's not ready for prime time.
Yeah.
And they're always ready to sell you personalized supplements, which you don't need.
Yes.
So I think there's a balance there. I mean, there are a lot of people who buy a watch of some kind, a ring, a Whoop, whatever it is, and then they realize it's making their sleep worse because they're too obsessed with the numbers. And I had that same problem with Duolingo.
You got the streak.
The streak was killing me, and I was tired, and it would just keep chirping at me. So I had to delete Duolingo.
I must say, I took off my Oura ring for that reason.
Okay,
It was just too much information. Looking at it all the time, got super obsessed with it. I just left it alone.
But I do think it's important for physicians to be open to patients.
I agree.
Bringing them that information.
Definitely.
And trying to put that in context for that individual's current scenario.
Definitely. It makes absolutely no sense that we say to patients, oh no, we're not going to look at that. Come and have one blood pressure reading with me, and that's the one I'm going to look at. But all of your 24-hour blood pressure reading from your brand new Whoop, I'm not going to look at that. It's ridiculous. It makes no sense.
It's such an opportunity to build trust for a long-term relationship.
And to build that partnership, because that's what it's about, really. We need a partnership with our patients, don't we?
Definitely.
Yeah. Okay, so now I know my risk. I've gone on, I've done the Tyrer-Cuzick score. I know that I am of average risk, let's say. What do I do with that information? So obviously I'm going to take it to either you, if I'm in Singapore, or a GP, or hopefully a doctor, to kind of discuss it in the context of my own life. But what do we then do? How does that then influence what we do with screening?
Right.
So let's talk about the age at which we start screening. So you mentioned it before about starting screening at 50, but that's not the case everywhere. So in the UK, we start at 50. With moderate to high risk starting between 40 and 50. But in Singapore, the guidelines actually say to suggest starting at 40. And I think the same is in the case in the US, right?
It's a discussion.
It's a discussion.
It's a discussion. It's not an absolute recommendation to perform, you know, these mammograms at 40. I think that it's reasonable to, you know, I think that you have to be educated as to what could go wrong.
Yeah.
And we don't want to scare people away from the system, but here's what could go wrong. I tell a story. Singapore sometimes, and a lot of countries, there's too much access.
Yeah.
And so-called executive health screening gets done. And what happens, you know, even with the best of intentions, someone will go for an executive health screen, a woman, and be told that they're going to get a pap smear as part of the package. 35-year-old woman gets this package. She says, oh, I have a regular gynecologist. I just had my pap smear. I don't need that. And then the transactional nature of that health screening, and I'm not going to say in Singapore, I'm going to put it in Thailand,
Yeah.
medical tourism.
Yeah.
And they say, well, it's worth a value of XXX. And why don't you do something else? And how about what sounds more safe than a breast ultrasound? The problem is that breast ultrasound might find a shadow.
Yeah.
And so it's the story I tell is, so they found a shadow and the patient is anxious, but the doctor's really good and says, listen, I see this all the time. Don't worry about it. We're going to do another ultrasound in 3 months and for stability, and then we'll say we're done.
Yeah.
And so they do that, and in 3 months it's the exact same. And the doctor says, you know what, we'll do it one more time in 6 months, and done and dusted because I know you're really worried about it. And so the patient feels relieved. But at the 6-month mark, she goes, it was her period. She had been wearing a sports bra, whatever. Something's a little different. And they're like, well, it looks slightly different, but it's really benign. It's really harmless. But you have an anxious person.
Yes.
And so the breast surgeon says, you know what, to satisfy you, I'm going to do a fine needle biopsy, not a knife, not a vacuum, not a procedure, just something in the office. So they do that. And, they look at the cells and they're totally normal.
Yeah.
They're absolutely fine.
This scenario is very common.
Right.
Very, very common.
And now this 36-year-old who had this screening mammogram as part of a package in Thailand just got a fine needle aspiration that says it's normal, just like I promised you. All good. At age 40, she goes for life insurance and can't get it because she had a prior breast biopsy.
And does that really happen? Do insurance
All the
companies do that even
All
though the
the
result was
time.
negative?
All the time.
That is outrageous.
It is. And it's usually fixable. It just requires a little bit, an extra letter.
Right.
It's usually something they can work on because people are being punished for doing the right thing.
Yes.
It's really kind of,
Yes.
odd.
Yes.
And it doesn't happen all the time, but it happens enough that I'm telling you the story. This wasn't an anecdote.
No.
In the
I hear
evidence-based
this
world,
all the time.
this is a really good case series.
This happens all the time.
And so often I actually in Singapore get called in for some of those cases to try to slow down the race to biopsy.
Yeah.
Because once you have that biopsy, if things are suspicious, it's kind of like you can't win until we find cancer, right? We're never as physicians comfortable saying it's normal. Like, don't worry, right? We're always going to be, 99% of the time. And, we cure stage 1 breast cancer 99% of the time.
Yeah.
But 100% of women think they are the 1%.
Yeah.
And so you really have to frame that ultrasound and that mammogram. And for the most part, I want everyone to do them. I just want everyone to go in eyes open.
Absolutely.
What are we trying to achieve? And what would we do with an abnormal result? Let's game that out.
Yeah.
So that comes up with genetics, where we're doing the risk assessment, and maybe auntie died of breast cancer, but mom didn't, and your sister had breast cancer, but she was 55. Where do you frame this? And so they want to do genetics.
Yeah.
What if I say your genetics are abnormal? Let's just assume we're not going to do the test.
Yeah.
How would you feel if I said you have a BRCA1 mutation variation? Would you be keen on bilateral mastectomy right now?
Yeah.
Would you at age 30 be keen on, MRI every year?
Yeah.
And as a non-surgeon, I've always historically advocated against the surgical risk reducing interventions.
Oh, that's interesting.
For most people, because I feel like the imaging and
is good enough.
But
yes.
I would say I've come 180 degrees over the last decade because I've seen so many women living MRI to MRI, and it becomes enough. I don't want to get a biopsy every 18 months. I feel like it's a time bomb ticking, and so you need to, just bite the bullet. You have to decide what's right for you.
Absolutely.
And I lay it out. I'm not advocating for it, but I want you to think on both sides of these You know,
100%. It's
what
not.
are your opportunities and optionality here?
Yeah, yeah. It's absolutely not black and white, and you can't just have a cookie cutter solution for
Right.
everyone, right?
Right.
Like you say, it's got to be risk adjusted, but it's also got to be personalized risk
Right.
adjusted. You know, I think for me, you know, and for women like me, you know, I think, okay, I understand that I might end up with some overdiagnosis or overtreatment, but actually for me, with 3 children, as a mother of 3, I would take that as a risk to get my 99% chance of cure if it's found at stage 1.
Right.
So I think, you know, for the woman who is anxious, who you know, doesn't have any family history, who would be that woman living, you know, year to year from that MRI, it's maybe not the right thing for her to do. But for someone like me,
Yeah.
do it.
You're like,
Absolutely.
I'm not
Do it
taking any
all.
chances.
I wouldn't take any chances.
I've got a young family.
Exactly.
I'm just going to, you know, go down this road.
Exactly.
I feel it's an obligation to, you know, to my kids. And
Exactly.
I will be here for them.
Exactly.
Even if it's, others might consider it overtreatment. For me, it's the right treatment at the right time.
Exactly.
That's personalized care.
So it's different for everyone. Exactly. Exactly. Okay. So we talked about it is the discussion depending on that woman's particular circumstances between 40 and 50. How often should we be getting them? So if we start at 50, if we go, okay, look,
Right.
I'm that woman. I don't want to go there. We start at 50.
You tell me for a second, because I think everyone's going to be shocked when you tell me. At age 50, a mammogram in Singapore, screening mammograms should be done how often?
Every 2 years.
Right. And how many people do them every year?
Yeah.
Everyone.
And you know why? Because I looked at something that said, if you, it was very nonsensical, and perhaps this was the wrong document, but between the ages of 40 and 50, if you decide,
then you should do it every year.
And then
you
from
do it
50,
every year.
You do it every 2 years, which,
Yes.
well, that makes absolutely no sense.
Yes.
We know that age is one of the biggest risk factors. So
Yes.
it made no sense to me either. I'm glad you picked up on that as well.
Yes. And so, and it does vary by country.
Yeah.
So
it would be, in the UK, it would be annually from 50.
Right. And so I think that that's an opportunity, and I see this a lot, where somebody's doing it, you know, they've started at 50, maybe they're low risk. Maybe I'll push to 15 or 18 months. You know, where does it fit in their life? I mean, because sometimes they're flying in from Jakarta or from, you know, Vietnam. Okay, I'm not going to be a stickler and say every 2 years, this is your big trip to Singapore. We're just going to do it at the 18-month mark. You come every year. You're comfortable with the every other year is because every year does result in more false positives.
Yeah.
And, you know, just more. I mean, that data, you know, which is old data now, the 10,000 women screened for 10 years between 50 and 70, the number of lives saved is relatively small for most people's appetite compared to the number of false positives. You know, I think 60% of women are going to have a false positive.
Can we just tell the
once.
listeners what a false positive is?
A false positive is having an abnormal mammogram when it isn't. So it's doing your mammogram, leaving the center, getting a call back that night or the next day that says, hey, this, you know, looked kind of funny. It's not cancer, you know, but we need some more images to make sure. Okay, that's a bad night's sleep. And, you know, worrying about the next steps. Or for a portion of those women, they say, hey, this looks pretty abnormal. We recommend a biopsy.
Yeah.
And a biopsy's done and there's no cancer. So the data from that study was a little more than 60% of the women, the 10,000 women in the 10-year window, are going to have at least one false positive.
Got it.
About 35% will always be normal. Amongst the 6,000 false positive group, about 900 plus will be taken to a breast biopsy that was, in a sense, deemed unnecessary or because of the false positive.
Right.
But I would remind everyone, part of this is why the breast cancer cure rates for stage 1 and 2 are 99, 98, 99%. And you know, high 80s for stage 3. Yeah. So we are overdoing it in so many ways, but we're not letting anybody fall through, you know, the net. Yeah. And so I think it's an education and a cost, you know, issue.
Yeah.
But yeah, the every other year is the right thing to do
Yeah.
in
So
the
the every other
appropriate
year kind of
50 to 69.
fits
Yeah,
that balance
it does.
between the
Yeah,
risk of false positives, but actually still wanting to catch it at that early stage,
right.
right?
And then understanding what the patient's motivations are,
Okay.
because I don't want to be a stickler and say, you can't do it this year,
Mm-hmm.
knowing that their best friend had breast cancer,
Absolutely.
right?
Yeah.
And so there are factors outside of guidelines.
Yeah.
I like to tell everyone guidelines are where we start,
Yeah.
but we are meant to provide personalized care,
Absolutely. They are guidelines.
personalized
They're
advice.
for guiding, not
Yeah.
prescriptive. Yeah, absolutely. Okay. You've talked a little bit about, so we've talked about false positives. That's when you get a positive result or something that looks abnormal, but it doesn't turn out to
But
be.
you're really normal.
But you've also mentioned overdiagnosis quite a bit. Can we talk a little bit about that and what you mean? How could you possibly overdiagnose a cancer? So people might not understand that. So can you talk about that?
If we knew the ultimate cause of someone passing away, then, and it's going to be, so let's pick heart disease. If, I was handed an envelope by a superior intellectual entity that says the person on my left, is going to die at 75, from a heart attack or a stroke, would I bother diagnosing, Parkinson's 18 months before? Is there value to labeling a disease when something else is a greater competitive threat to their mortality, to
Yeah.
their actual living?
Mm-hmm.
And so some breast cancers are diagnosed at such an early stage that they will not progress for a long time.
Mm-hmm.
They will remain curable. You could diagnose a stage 1A. You could have waited 2 years and diagnosed it at stage 1B.
Mm-hmm.
Both are going to be treated the same way, but that's 2 additional years of being a breast cancer survivor, of being, of not being a civilian.
Yeah.
And there's a lot of pre-cancer, the DCIS, ductal carcinoma in situ,
Yeah.
which doesn't meet the definition of invasive cancer. We call it a proliferative lesion.
Mm-hmm.
Cells growing abundantly, but not invading in the wrong space. But that is wildly overtreated, and our hands are mostly tied still in evidence-based medicine
Yeah.
that DCIS should be treated with surgery, often mastectomy,
Right.
and it's overtreatment. It's overkill. There are studies starting to come out about how we can manage it, observe it, and wait. But part of that cohort shows that these are women who are diagnosed with a problem, but they weren't ultimately going to die of this problem, or they died of something else in between that was more relevant. The same is true in prostate medicine.
Now, we've covered most of the kind of controversies around mammograms and screening, but I did just want to show you a quick video. We've covered false positives and we've covered overdiagnosis, and you've given me a good answer for those. I just wondered whether you would just have a look at this video and just see what you think about some of the other things that this doctor is suggesting are a problem with mammograms.
Why is a cardiologist commenting on mammograms? Well, it's just another example of useless and dangerous testing. So, according to the UK Independent Panel on Breast Cancer Screening and Cochrane Reviews, when you screen 10,000 women aged 50 to 69 every 2 years for 10 years, what you will allegedly do is prevent 5 to 10 deaths from breast cancer. But what you do get is over 1,000 false positives. You get 300 to 400 unnecessary biopsies, and you get tons of overdiagnosis and overtreatment. Big problem. Women and mammograms, the answer to breast cancer is not to get mammograms. That causes cancer as far as I'm concerned, the radiation. What you want to do is you want to do real strategies to prevent breast cancer, eat the right foods, avoid the wrong foods, live the right lifestyle.
Wrong message, wrong messenger.
Right.
And tarring everyone with the same brush.
Okay.
So it right there, I mean, we've spent 90 minutes talking about personalizing. Personalizing your screening tests. Personalizing your risk-reducing strategy. Personalizing treatment for women with breast cancer based on the subtype.
Yeah.
And this whole idea of risk-adapted screening and prevention, for me, originates in the women with breast cancer I've been caring for after their first round of breast cancer because now I'm the GP, the primary care doctor for someone with a history of breast cancer. And while I'm working to make sure they don't get breast cancer again, I'm working to make sure they don't get a different cancer again.
Absolutely.
And I'm working to make sure they don't get heart attacks or strokes or other things. So they were the original risk-reducing, personalized risk-reducing group for me. What happened in our practice was they were so happy with the care that I started taking care of their siblings, their spouses, their children and parents.
You came over to primary care.
And I came into if you had told me, oh my gosh, 35 years ago that I was going to be a GP, I was like,
you saw the light,
set
Stephen.
on
You
cardiology
saw the light.
or, oncology. I had to go out and actively save something.
Yeah.
But the hardest job in the world is to be a good listener.
Yeah.
And that's what being a primary care doctor is all about.
Yeah. And it's being an expert in your patient and not in a system.
Right.
Because patients are whole people.
Yes.
Not just
Come with
hearts
families.
or breasts. Exactly. So I just wanted to, because when I was doing the research for this episode, I went into social media to try and find a few videos for you, and I was horrified. Actually, you see what the algorithm brings you, and the algorithm brings me lots of evidence-based doctors, so I don't really see this stuff. But the number of accounts that were speaking just like him, I chose him because he was a doctor and therefore seemingly credible. But the number of accounts talking about mammograms do not save lives, mammograms are actually harmful, they actually cause cancer, was just astounding. So can we just directly address those? Mammograms do not save lives.
Mammograms save lives.
Okay.
Full stop.
Okay.
Evidence-based medicine continues. I think that we increasingly can offer screening for cancer and breast cancer at a more personalized level, but that is in evolution. The current standard would be mammograms beginning at 50 through 69 because they are proven to save lives. They do not cause cancer. Modern digital, mammograms have less radiation exposure than, a flight from Chicago to New York.
Yeah.
Okay. So, it's just, that's not the issue anymore. I think that it's important to go into the medical system eyes open, that even screening can bring harm.
Yeah.
And you have to be aware, you have to be a savvy patient, consumer, civilian to know both sides of the coin and be willing to accept that medicine remains an imperfect science and that we keep getting better and strive to be better, but we have to embrace do no harm.
Okay. The last thing he talks about is this alternative of what people call QT scans or thermograms.
Right.
And again, that's got a huge traction on social media about, you must go and avoid the radiation by having one of these. It's not one that I'd even heard of. What are they? So
a whole variety of other imaging modalities. It's not limited to imaging. We work with a lot of companies that do the so-called liquid biopsy, circulating tumor DNA for screening. And there are combinations of novel techniques in imaging married to novel techniques in blood-based analysis. And you can layer those on each other. The imaging is called radiomics. So we turn digital images into digital biology and statistically say, well, this cyst looks, this cyst and this cyst look the same, but when you apply the blood test on top of them, algorithm says more suspicious, less suspicious.
Amazing. Maybe
Maybe do a biopsy or not. But none of that is evidence-based medicine yet. It's available, it's out there. They can be complementary, perhaps, but they're still not evidence-based medicine yet. I do think the breast imaging space will move quickly to some of these other techniques, which can be ultrasound-based, MRI-based. MRI without contrast is going to be a thing for breast screening in the future. I'm really keen on advanced MRI augmented with AI. We're going to need more radiologists, not fewer. So I think that imaging, liquid biopsies, will solve the problem that annoy the TikTokers.
Yeah.
But they'll have something else to report back later, I'm sure.
Just going on to that, do you ever get any women who say, well, if MRI is so good for the high risk women, forget the mammogram, I just want the MRI. Can I do that?
There are complementary methods. I say it's, taking a photo, taking a satellite photo, taking an infrared photo. So mammograms, ultrasound doesn't replace mammogram. They are complementary imaging techniques that, and MRI is the same. So we don't, an MRI alone is not going to be a useful tool. We still, in a high risk woman, we would get MRI, mammogram, and ultrasound.
Okay. So let's just briefly talk about risk reduction. So just give me your kind of top things that you advise all women who are worried about their risk of breast cancer. What should we do to try and reduce our risk?
The number one risk reducing intervention for men and women for breast cancer and chronic illnesses across the board is exercise. And that's evidence-based medicine advice.
Yeah.
In breast cancer specifically, it reduces the risk of getting breast cancer, reduces the risk of breast cancer relapse, reduces the risk of dying from breast cancer, reduces the risk of dying, period, in women with a history of breast cancer, and improves the quality of life in women undergoing treatment for breast cancer. Those 5 statements are from randomized clinical trials of exercise in breast cancer. I can't say the same thing in colon or lung. I can always say it improves quality of life, but that high bar has been met in multiple studies in breast cancer.
Yeah.
And across the board, exercise prevents disease.
Yeah.
Now, if exercise is a drug, what's the dose, right? And I used to have a prescription pad.
Did you?
in the office,
Yeah.
And I need to bring that out again. And you would literally physically prescribe exercise, and you could put on there 150 minutes a week of moderate intensity, 90 minutes of high intensity, functional training, strength, and exactly what to do. And it obviously was more of a gimmick to get people motivated, but you do have to know what's the right amount.
Yeah.
I like to joke that walking is not exercise unless it's that really highly motivated, speed walking.
Yeah.
Walking is just movement, but strength training.
Movement is still good.
Movement is great.
Yeah.
Absolutely. But
Yeah.
it's not an exercise replacement. And so strength training 2 or 3 times a week, a little bit of high intensity stuff, or we argue how much high intensity versus zone 2, but really it's 150 minutes of moderate exercise plus 2 sessions of strength.
Okay.
Yeah.
Now, we're in Singapore, and as expats, we do like a bit of alcohol. Talk to us about that, because one of my favorite infograms is going on to the British Menopause Society website, and they've got this beautiful infogram which looks at it just details the number of extra cases of breast cancer you get from HRT, and they compare that to the number of extra cases you get from alcohol. And every time I show it to someone, they're like, what? They also have BMI on there, which is way off the scale.
Right.
So just talk to us about some of those risk factors that we don't really think of.
So alcohol first, so let me back up, because the number one cause of preventable cancer after tobacco is obesity. And that's where the GLPs come in, where a sustainable diet that reduces body fat. And I would advise everyone, like, what's the goal? I like asking patients, what's our goal here? And when they don't have an answer, I'll give you the answer. One is, we don't want to be obese. We don't want to be overweight.
Yeah.
We don't want to be diabetic, and we don't want to be pre-diabetic, and we don't want to have fatty liver. Though those are the conditions or preconditions, pre-diseases that I think we should try to abolish in our patients, extinguish, because those, I'm not seeing people die of that directly. Those have consequences in heart, in Alzheimer's, in cancer. So the metabolic thing and the obesity, that's the number one cause. Where does alcohol fit? And you can look up infographics that are going to have those numbers, but it's a really controversial area in some ways, because the messaging is that any amount of alcohol is going to increase your risk, like it's a single stick of cigarettes. And, at the American Society of Clinical Oncology, the world's largest cancer organization, there are very loud debates about whether we can do an abstract review program at the annual conference, which used to be a wine and cheese event. And it's just like the cardiologists and, selling cigarettes in the 60s. Can we really do this?
Yeah.
Right? And when you look at the data, it all depends on how it's published. You can make a statement that says any amount of alcohol will increase your risk. I would also say that if you purchase a lottery ticket, you are at an increased risk of winning the lottery.
Yeah.
So it's statistical, it's measurable, it's not meaningful. If I buy 100 lottery tickets, my risk of winning will go up 100-fold.
Yes.
But it's still not a meaningful risk. So where's the danger? I don't think there's a danger in a twice a month Sunday champagne brunch. I don't think that sharing a bottle of red wine on Friday night with your partner is a problem. Binging is a problem. Excessive amounts of alcohol is a problem. The regularity is a problem.
Yeah.
And
So
all
daily drinking.
Daily drinking. The historical recommendation was no more than one drink, 1 unit, whether it's a shot, a glass of wine, or a beer, for women, no more than 1 a day. But it's the binging data. The real driver in the headlines that we see is in the excess, the top 25%.
Right.
There's a famous economist statistician, Nicholas Taleb. He wrote about black swans, and he writes very well about how the alcohol statistics are problematic.
Yeah.
And they're challenging. I wouldn't just say throw it all out. It's that it's really the excessive top 25% that are dragging the whole boat along. But that said, it's not that we don't see a benefit in the alcohol. Right? There's no cancer protection.
Well,
there's no French paradox.
I think social connection,
health,
friendships, family.
True. I agree. I mean, there's the warmth of, the social.
Yeah.
I absolutely see that part in terms, I often joke, like, if you don't drink coffee and your boss says, I want to take you out, let's go grab some coffee and talk about your future. You're like, I don't have coffee. Wrong state. Yeah. Just go have tea. Yeah.
Exactly.
Yeah.
Exactly.
The other, it's tobacco, it's obesity, it's alcohol, not about breast cancer, but don't forget infections.
Yeah.
Okay. Infections are a huge driver of cancer in the world. HPV and cervical cancer, of course, HPV and head and neck cancer in men and women, HPV in a variety of cancers.
Great example.
Hepatitis B and C, H. pylori in the stomach, Epstein-Barr, and lymphomas. Infectious diseases are really important.
Yeah.
And so taking a logical and evidence-based approach to monitoring, screening, preventing, avoiding is also critical.
Yeah. Thank you so much for coming on. We have covered an awful lot.
I thought we were done, and then there's like rapid fire.
I'm going to use you, so I'm going to get all the information out of that brain. Thank you very much for coming.
It was a pleasure. So much fun.
Thank you. It was a lot of fun. Do you have just any takeaway messages for women who are either worried about their breast cancer risk or have navigated having breast cancer and have come out the other side? What is your advice for them?
I think it's important to find positive stories, to find survivors, and to have an honest story about how they presented, where did they get treatment, how did they perceive their treatment, how, some days are horrible, right? And you feel like you're just stuck in this dark cave. But everyone comes through on the other side. And no one asks for this, but there is a way with growth mindset and framing to really see any problem in life as a challenge that you will get through, and be braver and stronger and more resilient for having to go through the process.
Yeah.
I think if you're using a device, a person, you sort of ask both sides of the story.
Mm.
It's easy to say what could go wrong, but tell me more about what went right
Mhm.
and what you learned about it.
Yeah, that's a beautiful message. Well, thank you very much, Stephen.
Thank you.
Great to have you.
Fun.
And that's it from us at the Women's Handbook podcast.
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.